Hello, everyone, and welcome back to this episode of the Akal and Koka Report. We have a special guest today. Returning to the show is Dr. John Mandrola, who will need no introduction for many in our audience who know him. But for the few who don't know him, Dr. Mandrola is a cardiac electrophysiologist in Louisville, Kentucky, and a thoughtful writer and commentator on all things medicine. So, I'm repeating the intro that I gave you on episode number 12. For those those who are paying attention, I'm just being lazy here, but Dr. Mandrola is an early participant in the medical blogosphere, and he built a large and faithful following, first on his own website, drjohnm.org, and subsequently as chief cardiology correspondent for Medscape, where he publishes regular columns and hosts a podcast. He is beloved by many for his heartfelt dedication to medicine and loyal commitment to patient care, and his candid criticism of our healthcare system. John, welcome back to the show.
Hey, thanks for having me. It's a real honor to be on twice.
It's great to have you. And well, speaking of having you on twice, we've received some complaints from listeners that we handle our guests with kids' gloves. So that we've decided that whenever a guest comes back for the second time, the gloves are off. Okay. So,
fair enough.
Just a little warning here. All right, John, you wrote a very, very provocative article on Medscape, a blog entitled Independent Nurse Practitioners and Physician Assistants, a Doc's View. We'll have a link to that on the show notes. It received 538 comments as of today. I think you really, you hit a nerve, not just a nerve, you hit a C fiber, the C fiber of the pain nerve, you hit it with a sledgehammer. So the article was in a commentary on a recent executive order by President Trump that essentially directs the administration to give more independence to nurse practitioners and physician assistants so that they can practice without supervision, as is currently the case, and to work towards pay parity so they get paid just as much as a primary care physician would get paid. And you took the position that it's okay, there's nothing wrong with that, and perhaps even some good can come out of this. So we'll get into, is this a fair summary? We'll get into the details of your arguments, but is this sort of a fair overall assessment of what you wrote?
Well, almost. I would say that, and we had this debate about the title, and I would say that my take was more that it wasn't going to be the apocalypse, that it was going to happen. It is happening. And I don't think it's going to be as bad as people think.
Okay.
And I think that's the gist of it.
Okay. Right. And you see, actually, I mean, I will get into this, but you see that there may actually be some benefits, here and there. You mentioned a few things that are maybe positive. But let me ask you this, John. You are in the one of the four horsemen of medical conservatism, this new movement that is becoming very popular with your colleagues, Dr. Sifu, Dr. Prasad, and Dr. Foy. And, knowing you and knowing what you've written over the years, in general, whenever there's a change in medical practice, something being introduced, your stance is to be very skeptical, to say, no. Really, let's make sure that it's an improvement. Let's make sure that it's better. Let's not adopt something radical here. We're going to be medical conservative. This should be the default attitude. Is there an inconsistency here, or what? Tell us about it. Or do you think the evidence is strong enough or compelling enough that the change can be made?
Well, I appreciate you bringing up the medical conservative thing. Thank you. We're trying real hard.
Okay.
I think the link is this. The reason why medical conservatism is so attractive to us is the core principle that doctors don't really control as much outcomes as they think they do. So the reason why the default to medical conservatism is, I think, so attractive is that we don't have as much of an effect size as we thought. For instance, if doctors were in a randomized controlled trial, you would need to take thousands and thousands of patients in the trial to show a difference. Say we were being compared to nurse practitioners or PAs. So yes, and I made this point, we do great things, and I love being a doctor, don't get me wrong. But I think that all the training we do and all the things that we think we do are pretty marginal benefits when you say you stack it up to good, good sanitation, clean drinking water, clean air. Compared to all that, our effect size is small. So the medical conservative believes that the doctor is helpful, but is maybe not as influential as he or she thinks they are.
Okay. I'll probably come back to that, because I'll have I mean, I find that a very provocative position myself. But so you think that doctors, we don't control outcomes, and therefore you think that the introduction of nurse practitioners is not going to change much? Is that the idea?
Yeah, I think that if you look at a bell curve, a Gaussian curve, I think that for the average effect will be very, very small. I mean, already nurse practitioners are doing so much in our hospital and many hospitals. Okay, so technically they have supervision, but they're making a lot of medical decisions in subspecialties in primary care, and people aren't dying in the streets. I mean, I just don't. I mean, I just don't see any bad effects. Yes, of the 580 comments now, there are a bunch of anecdotes, and people have mentioned anecdotes about this nurse practitioner screwed up or this or that. And I'm like, please don't even tell me that, because I mean, I've seen over 24 years, I've seen plenty of doctors screw ups. I mean, heck, I've screwed up. So
right.
Yeah.
But
John,
I mean,
you think?
if hang on, sorry, Anish, just one thing, just to go back to my question. If doctors don't control outcomes so much, then why make a big deal about the introduction of anything, whether it's atrial fibrillation ablation or this or that? I mean, if you're going to make a change, why be so skeptical about the changes that are being made? And you say you demand outcomes for devices and for drugs and whatnot. Are you demanding the same kind of outcomes for the introduction of nurse practitioners? And if not, why not?
Yeah, I think look, can I just tell the story of Dr. Lloyd just real briefly?
Yeah, sure. That's
So-
in
so-
your your article.
It's in the
Yeah.
piece. It's in the
Okay.
piece. I'll make it brief. But so, Vin and I did that beautiful study a number of years ago where he showed all of these medical reversals. He wrote a book about it, and I read this article. It was just in the Mayo Clinic proceedings a couple of years ago, and I thought, oh my gosh, we're just doing all these things, and then they get reversed. And so I wrote this essay, and Dr. Lloyd, who's this senior guy, I mean, he was Baptist minister before he was a pulmonologist. He just walks around and everybody listens to him. He wears a suit and tie everywhere. And he sat me down and he said, John has a great essay, but you don't understand. We doctors don't control outcomes as much. And I was like, Dr. Lloyd, what are you talking about? I'm a cardiologist. I control lots of things. And he told a story about two patients with sepsis. One that he was sure was going to die and treated him in the usual fashion. Next morning, the guy's up eating breakfast. And another patient who was much less sick, he thought he was going to live, no problem. And the next morning comes in, and the patient's died. And so when I heard that, I thought, holy cow, well, maybe we don't control outcomes as much as we did. And so that's really changed my view of being a medical conservative, knowing that I'm not advocating doing dumb stuff and not treating people who are sick. People who are sick need treatment, but I'm advocating just saying, holy cow, we don't really have as much control as we think we do. And as far as the nurse practitioners and PAs with much less training, I think there is some data. I agree that it's not the highest level data, but the studies that have been done, biased as they may be, low level evidence, they don't show any major differences between physician-led care. So yes, we should study this more. Nurse practitioners are becoming more independent. This is easy. We could easily do cluster randomized trials where you randomize an ER to a nurse practitioner independent versus not. and then we could look at outcomes. You could do it within systems, and it should be done. And if those trials show that doctors do better, then I'll change my view. But there's not a shred of evidence that they do.
Anish?
So, John, do you think, say we for a moment accept the medically conservative philosophy? Do you really think that nurse practitioners or folks that perhaps don't have the training, don't have the background that an experienced clinician may have, do you think that they're the best envoys for medical conservatism? You mentioned in your piece that there's a fairly reasonable data set, a fairly good amount of folks that would agree that more nurse practitioners may result in more consultations, and more nurse practitioners may result in more downstream testing being done, right? It takes a lot of experience to stop cascades, right? We talk a lot about cascades that get started off with testing that happens, just with the lowly EKG. Who's in a better position to look at an EKG with T-wave inversions inferiorly and say, all right, this person does not need any other testing? Is it a cardiologist, or is it a nurse practitioner who's practicing, again, independently? Not a nurse practitioner that can run over to you and say, hey, take a look at this. What do you think I should do? So I think even if we kind of go along with medical conservatism as being, the default best way to practice, I would have some serious concerns if I were you about the coming world and how it is, how closely they're going to hew to that.
Yeah, I agree. I think that, so I looked at this when I was doing the piece. I did looked into the data, and it does look like the less experienced the clinician, the more testing they're going to do. And I mean, that there was a study I cited with interns and residents, and they do more testing, and I think that will be the case as nurse practitioners come on. And I'm not advocating for just throwing an untrained nurse practitioner into the wild. It's really, I think, the best model, and there's not enough words in the piece to describe this, but the best model would be an apprenticeship model. I mean, I work with a nurse practitioner who's been in cardiology for 25 years. She's done devices, she's done heart failure clinic, she's done all of this stuff. I mean, she is an amazing clinician. But, if she tried to go to the dermatology, and she could, I mean, she would have no training. So I think the best case scenario, and I think most of the nurse practitioners and PAs would agree, that a period of apprenticeship with an experienced clinician and staying within that field is the best way.
But there's an issue, right? I think there's clearly some very, very talented folks who are not doctors, who don't have that stamp or that certification, who are tremendous who are tremendous at delivering healthcare, have a great eye, all the things that we would like to see in terms of a good clinician. But your nurse practitioner, who you've worked with so closely, who's very experienced, is really, really good, and you like her and you value her so much, in part because you have imparted a certain amount of values to her, right? The issue comes in is that, so in some ways she's good because of you, right? If say you were to move away, there were say somebody else that were to come on, correct? Now, and they had a very different value system or a very different way of practicing, that would imprint onto her. So one of the issues is that they're certainly very, very good at putting protocols and at following protocols and following guidelines, which is good in some ways, right? But you of course have written so much about how guidelines are somewhat corrupted, and you really need a lot of critical thinking to kind of look through those guidelines, to look at the primary data to decide. So I think it's challenging. I think if you're looking at the landscape of cardiology, say, right, and you see a lot more bad than good happening in a systematic fashion, John, I think I would be very, very concerned that we won't name names, but nurse practitioner with X, Y, and Z is going to be very, very good at signing up people for TAVRs. I don't know if you took, I don't know if you actually, I don't know. Did you take a listen to the one podcast we did with the wonderful patient of mine who was 89 or something like that, and she had a TAVR done, and her description of the process was just just amazing, and she barely spent any time with any physicians, right? Most of the time was spent with a nurse practitioner, a PA, I think. And the thing that kind of finally pushed her, she was this reluctant to go along with the TAVR because she kept saying to me, I feel fine. I feel fine. I felt totally fine. I don't know why you're talking to me about this, right? Finally, the thing that kind of pushed her over the edge was a nurse practitioner telling her that you're going to die unless you get this aortic valve fixed.
Well, come on now. That's not fair. I'm just going to fight right back because
no, go ahead.
I have heard. I mean, if I had
my point is not that the nurse practitioner herself. I don't think that he or she was bad. It's that they're operating within a system, and they take on the imprint of that system. It's too much, I think, to ask that nurse practitioner working within the system that they're working in to say, you know what, I really don't think this TAVR is the best thing for you. I mean, I could say that within a system. You do it all the time, right, John? You all the time, will say, look, I don't, you're doing it right now. The Watchman's, right? But again, can you expect the same type of thing from a nurse practitioner to be able to look at the data and say, hey, I think this Watchman, I don't think the Watchman is right for you. I don't think they're going to be able to stand up to the system in a way that someone like you can.
Oh, okay. I just think that if I had a nickel for every time I've heard that a doctor pushed a patient into a procedure by using fear,
right?
Or whatever. So I don't think there's anything specific about a nurse practitioner.
No, that's not the point. The point is not that you understand the point I'm making. I'm not making the point to say an anecdote of where a nurse practitioner did something bad. I'm saying she's doing, she or he are doing exactly what they're supposed to do, working within a system that wants to get a TAVR, 10 TAVRs a week.
But so you're making the case. Let me understand this: that a nurse practitioner or a PA is going to be more, is going to feel more pressure from their system than a doctor.
I don't think they'll feel pressure. I think they're just going to do what the system tells them to do. I think whether you look at lactate protocols that require 10 liters of fluid, like how are medical reversals actually engineered? Medical reversals are engineered by a physician looking at the reverse trial and saying, you know what, this patient who has an EF of 30%, whose pulse ox is 92%, has some pulmonary vascular congestion, maybe I shouldn't be giving them XCCs per kg, right? The tidal volume, the large tidal volumes, right? It requires the clinician to say, you know what, these plateau pressures when I ventilate them at so and so are causing these massive plateau pressures, and we need to not do this.
But Anish, why do you think nurse practitioners are more liable to go with the flow than physicians? What is it about us clinicians or physicians that make us different in that respect? Is it medical education? Because I think John had something to say about medical education and its value, right in shaping what we do. So what is it about? What do you think is there's a difference? If you think that if you allege a difference, why do you think that is? John, I mean Anish. Anish, sorry, Anish.
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 You're talking to me. Sorry.
No, Anish, sorry, you're making a claim. So why do you think if you have an MD after your name, it makes a difference
exactly.
in
because there's value, because you understand. It's like knowing how to do a math problem, right?
Yeah, but how do you get to that point? What? No, at the end of the day?
Let me finish. Yeah, so it's like understanding. It's like understanding a math problem by memorizing how to do something, right? It's like so if you can memorize things and do calculus, or you can understand what an integral is and why you're doing that, right? And one person, when you compare them on a test, they may do just as well. But when you present them with a new problem that requires them to understand the concept, I think they're going to struggle.
Again, does it happen at the selection level in medical school? The kinds
both,
of what it takes to get into medical school, or what you actually learn in medical school, or the exposure that you get.
Both. I think the selection piece is critical, and John didn't talk about that. That that the group of doctors are selected in a very different way than the group of nurse practitioners are. So that I mean the ability to. So that's one, and then but the second is also there's just so much more background base level of training, right? I mean, again, you can teach anyone how to do a technical aspect of things. To teach them how to understand them and to operate based on understanding the concepts, that I think takes a much longer dedicated amount of time. So both things, I think you can't take, so.
I want to push back.
Yeah.
Hold on a second. Hold on a second, because Anish, I agree with you 100% if you're talking about a nurse practitioner or PA who's out of training 1 or 2 years and they just finished their school and they're going into the ICU to treat sepsis or whatever. They have no clinical experience. But let's just say someone's been working in an ICU maybe as a nurse before they were a nurse practitioner, and then they go to nurse practitioner school and they're working with an ICU team, pulmonary team, whatever. They've been doing it for 5 or 6 years or whatever. I think it's really crazy that we think that a nurse practitioner or PA who's doing this for 5 years and who has an internet access can't learn what they need to learn to have this judgment, seeing patients every day. Like an electrophysiologist, I go back to my nurse practitioner. She not only follows protocols and understands things, she like kicks my partner and I in the shins and says, "You dumb butts, what are you doing? Why did you do this?" Because, she has experience. So I agree with you if you're talking about a 2 or 3 years of experience, like just out of school, like an intern or resident. But some of these nurse practitioners who stay in this field with the ability to do medical education, if they're motivated and they want to read and they want to learn, they're no different than anybody who went through medical school or residency. That's crazy. I think that 2020, people can educate themselves to be amazing clinicians.
Okay, but let's be clear, John. The executive order would allow, as far as I can understand, would allow a pathway where a nurse comes out of one of the diploma mills, and I think there are thousands of online diploma mills now, right? Get a degree as an NP or PA or whatnot, and I don't think the government is putting any provisions that they should be under the supervision of seasoned clinicians. I may be wrong, but I don't see that. And I didn't see that in your piece that much. I mean, I think this is something that you're introducing. You say a little bit of a caveat. You say, well, they need to be sort of trained under competent clinicians for a period of time and that sort of thing. But I think that's fine. I mean, I think that's a defensible position. But I just want to make clear that we understand things correctly. Is the executive orders, is the executive order promoting something that you are supporting right now by saying that, they should have apprenticeship and whatnot, or not?
I'm not saying I support. I'm not saying I support throwing untrained people out there with little training. But let's just say that we give the nurse practitioner or the PA the benefit of the doubt. Let's say that they're not going to go with 2 years of training and start doing medical practice that they have no experience with. That most of the people are going to get into a job where they get comfortable with it, they work with someone, they learn. And I really don't think it's fair to think that most of these people are just going to want to just go willy-nilly out there. But then I want you to circle back, Michelle, because I want to circle back and say, even if they did, even if they did, do you think that there would still be an apocalyptic type effect if untrained people started treating people? And I really, really wonder in 2020, with all the backup and the fail-safe mechanisms, if that would happen.
We'll get back to that. I think it's a very important point. We'll get back to that. But to make sure that I understand, if the world was according to your wishes, then you'd have nurse practitioners who'd come out, who'd spend a few years learning from clinicians, and then sort of gain experience, and then be able to practice on their own, and the world would be fine, and they'd be able to practice independently without any further supervision, and the world would be fine.
I really think that just take the average person who comes out of nurse practitioner school. I really think that I really think that they want that. They
Okay.
want to
No,
be comfortable with
right.
that.
Now suppose a nurse practitioner has followed that pathway, has trained with you for 5-6 years, or clinicians like you, is now practicing independently for 5-10 years. Now, can they themselves start to train nurse practitioners fresh out of school, and chaperone them for a few years, and then launch those second generation nurse practitioners independently into the clinical arena?
I
Right?
can't imagine it. Yes, I can't
Yes.
imagine that would be a
Okay.
problem.
So in a way, there's a way to you conceive of a way of practicing medicine without physicians whatsoever. Eventually, right? Because eventually you would have a completely independent medical school, free, without any attachment to medical school, a pathway to practicing medicine that has nothing to do with medical school. And again, be careful, because I'm not falling on one side or the other on that question. So we'll come back to that. But I just want to, I want to understand clearly where you stand.
Yeah, I think you're pushing me a little bit with these hypotheticals, but I think
Right,
that,
but you make comments in your paper about, we don't need to learn, we forget half of what we learn in medical school. We don't need to
yeah,
learn the Krebs
more.
cycle or more and so forth, which I think are very, very valid points. And therefore, the question becomes, what makes a doctor, or what gives someone what it takes to practice
Yeah,
medicine? Okay.
I guess so. That goes out a little bit into it goes a little bit out of the argument to more of a philosophical argument, but
With
really,
me, it always goes back to the
I
philosophy.
understand, but I was putting in pacemakers today, and I thought to myself, putting in a pacemaker, for instance, is way easier than fixing my bicycle. I mean, I just cannot figure out the drivetrain of my bicycle,
Right.
and I could train anybody with decent hands and a decent head to put in a pacemaker, and they might be better at it than me. So, really, what is it about? What is it about going through all that hazing, medical school, Krebs cycle, whatever, OBGYN rotation, like all this stuff. And now I can put in a pacemaker, but someone who, let's say I trained them to do it for a year and they did 100 cases, why couldn't they do it? It's crazy.
Correct. But if you follow that logic, then there would be there'd be no medical schools. There'd be everything would sort of dissolve. How would you have anything, right?
Yeah,
because everything can be learned and passed on, sort of,
yeah.
by apprenticeship or word of mouth, like that, or.
So I went, when I visited a lab in Germany, to learn some ablation, and I went in there, and I couldn't believe, as an American, this was a few years ago, that they had extremely young people. I mean, these were like intern level people doing complex ablation and learning to do complex ablation, things that I did after many, many years. And these young people were really good at it. And they hadn't even done any medical training, but yet they were super skilled in doing an ablation procedure. So, these European countries are not so crazy. I mean, they're just doing it differently than we're doing it. So we're stuck in this model, and we do it because that's the way we do it. I'm not sure that that's the way it has to be.
This is a dystopian view of the future. Meaning, this is not what would make Don Abedian happy, right? Meaning, if you just have folks that are subspecialized, that are very technical, right? It defeats what it means to have a relationship with someone called a doctor. Meaning, I already think it's a problem that we are subspecializing as much as we are, because it creates a massive amount of fractionation of care, right? And if you read what Don Abedian said as he was dying of bladder cancer, right?
So just for the audience, Don Abedian was a guy who was, he's considered the father of the quality movement. He was all about, measuring outcomes and whatnot and so forth. And at the end, and he was a sort of a giant. And then when he died, he reflected on the healthcare system and said, it's so fractionated, so mechanical, and so forth. And we've lost, the essence of what it is to be a doctor.
Right. So if you kind of take medicine and you break it down and you silo it into these little parts, and you're absolutely right. I'm sure there's folks, we don't select folks for good hands, I don't think, when we're selecting people for med school, right? So I'm sure there's wonderful technical folks who can do stuff way better than whoever we can. And you see that And you see that in how, something like CT surgery has evolved, for instance. There's residence nurse first assists who are very technically skilled and do a lot of the steps that it takes for a CT surgeon to do, right? But there's certainly something to be said about having having that relationship with the patient over a long period of time, and making these decisions with them, and kind of holding their hands, if not literally but figuratively, through that whole process. If you break it down to a very what you're talking about, the reason I said it's dystopian is because then it becomes very technical. You have a guy who just puts in pacemakers all the time, and that person, that whoever that person is not going to be able to figure out whether or not the patient should get the pacemaker or not. You know what I'm saying?
I completely agree. I completely agree with that. And I think one of the reasons why I love electrophysiology so much is that on one day we're in the lab, messing around with these complex systems and mapping systems and devices, and it's just extremely technical. But on the next day, we're seeing patients in clinic, and we're helping them with just basically living life and making relationships and seeing them through life. And I've been now 25 years, so I've seen patients through their whole, arc at the end of life. And it's beautiful. But Anish, there's absolutely zero of that requires having an MD after my name.
But what I think you're missing, no, you're right. The MD is superfluous, but I think you're not, you're at least discounting the skill and talent it may take to be able to go from A to Z in that whole process, right? Meaning you're a very talented guy. I know you may not think so, but you're an incredibly talented guy. You're very compassionate. You also, snake catheters and wires into the heart. You map AFib, you map X, Y, and Z, and you're able to ablate. You also have a good understanding of who should and should not be in the lab. Meaning, these are things to have that skill set to go all the way from one to the other. That is not something that is a dime a dozen in society. That's a select group of folks that can do all of that. So yes, any one single thing you do, John, can be replaced by someone who doesn't need 10 years of training. But I think you've made it. It's not going to be easy to get somebody like John Mandrola to do
Anish,
all of what John Mandrola does.
Let me try to understand a little bit. I'd like you to articulate a little bit better what your view is, because on the one hand, it sounds. I mean, if all it is, it's holding people's hands, and it's very touchy feely. So are you saying that?
Are you talking
doctors? Yeah, you, Anish. Are you saying that you want doctors need to be very competent technically, but also be touchy feely and hold people's hands for the rest of their lives?
Oh yeah, I mean, absolutely. That's what we've kind of lost by having folks that are PVC ablation experts, right? Like, they see a PVC and automatically it's like, well, what's the
but I can tell you that there are lots of patients who would say, I don't care about the touchy feeliness. I want the guy who can, fix my heart or fix my liver or fix whatever it is. I want somebody who's really super competent.
Right. Well, again,
and I can take care of my own, touchy-feely thing with my own family and my own my Baptist preacher and whatever it is.
By touchy-feely, I mean having a relationship with a patient so that you can come to an understanding of what it is he values and what it is he wants. And sometimes you have patients
shared decision making.
No, not shared decision making. Sometimes, sometimes you have patients that desperately want some procedure done, and you as a physician feel that this is not something that they need. So there's that conversation that takes place that I think makes for good physicians and makes for good healthcare. And at the end of the day, we all want good healthcare for our patients. We don't necessarily want a commoditized world where dialysis is on aisle 1, okay. PVC ablation is on aisle 2, right? And I really fear that if we're not careful, the world John is talking about will lead us to that. I mean, and the other thing that isn't talked about, I thought, John, in your piece, was that patients don't have a choice anymore. Like, fine, you want to have a world where you don't have licensing and stuff. Okay, fine. But then make it so that patients have a choice. Right now, patients are referred to academic quaternary care centers for pulmonary hypertension clinic, and they don't have a choice. They see a nurse practitioner. The nurse practitioner may or may not be talking to whoever, or maybe collaborating with somebody, and that's it. And I don't think I don't think we're being given a fair chance. And what's going to happen? I mean, fine, make the playing field level, and let patients choose with their dollars what they want to do with it. If they want to spend it on, the group of nurse practitioners, then fine. If they want to spend it on somebody like John Mandrola, okay, like let them choose. But right now we're not giving them that choice. So that's why I don't think any of this is fair or level playing field for physicians.
Yeah, two comments.
Yeah.
One is that's how I close my piece. I think that if it were a truly free market and there were no
Right.
coercion,
Right.
then I think that that would be the best, because people could just decide whether, just like you decide whether to buy a more expensive coat or sneakers or whatever, you could decide whether you wanted to pay extra money.
Right.
But I really don't want to devolve this podcast into a discussion about healthcare policy, because it's not, I'm not an expert.
Right,
I'm not
right.
an expert. But the other thing is, the second comment is, I want to admit that I think the biggest weakness in my argument, I think the biggest thing I was most concerned about is that maybe it's like David Foster Wallace's fish. Maybe because I have 20 years of experience, because I've had all these mentors, because I have these great colleagues, that maybe I can't see the effect that, all of this training has. And so maybe it is what it is for me, but putting myself into a shoes of a less experienced person, maybe I don't know. So I think that is a weakness.
Yeah, I think that's exactly right, because I want to come back to what Anish was saying and press you, Anish, a little bit further, because what you're, I agree with you. I'm giving you a hard time, but the reason I'm trying to press it is because I don't see anything explicitly in the medical training that either selects for or imparts to students what it is, the values that you're talking about. There's absolutely nothing in the selection process, in the MCAT, and in the USMLE step 1 and 2 and 3 and the Krebs cycle and everything. So if there's nothing that you can identify in that medical training system that imparts what you're saying, that, then where is it coming from, and why shouldn't a nurse practitioner get it by spending 5 years with John Mandrola?
No, it has to do with So I part of my disagreement with
and I'll tell you my opinion and where
yes,
it's coming from at the end, but go ahead. Yeah.
Part of my disagreement with Dr. Carmody, Brian Carmody, who's a pediatric nephrologist who we had on talk about the uselessness of the step 1s and how, doing away with it to take away the pressure and stuff, is that there are, I mean, all of life seems to be some type of filtering process to try to figure out, to try to get you a group of folks that are able to do a job at a certain level. So I don't know that necessarily every single step in the process has to necessarily be useful at the end, but your ability to and this is well understood by in the military, for instance, right? There's tons and tons, like, how do you get SEAL Team 6? SEAL Team 6, they're doing tons of things getting up to that point that have nothing to do with their ability to go into some Abbottabad, some suburb of in Pakistan, and get in and take out Osama bin Laden. I mean, there's so many steps that they've taken up to that point that are like their Krebs cycle. It's like, what was the point of doing that? But the point is to be able to find and select a very elite group of folks. And the question is, so what does organic chemistry have to do with becoming a good doctor? Not too much, but at some basic level, like concentration, being able to regurgitate, being able to memorize a significant amount of stuff. I mean, there may be some basic skills there that you may want, physicians to have. Meaning, organic chemistry itself doesn't do anything, but simply the ability to be able to jump through those hoops is perhaps how you get to somewhat of an elite group of folks. And again, so my point to Brian was that we probably need to have a system that's even more elite, meaning we shouldn't dilute this too much by necessarily, if you go and if you go volunteer in some place in the Sudan, have that have an equal weightage to being able to get a 3.9 GPA in chemical engineering. I mean, there's different skills there. Now, whether or not that 3.9 GPA in chemical engineering has anything to do with being a fantastic doctor, that's a whole different thing. But basically, if you're able to get a 3.9 GPA, then you may have some level of intellectual heft, so that when you see something coming down the line that is a current practice that you want to reverse, you may have some ability to do that. It's a very long-winded answer, and I apologize, but my point is, you don't need all those steps in the process. They don't have to add up to something, but your ability to jump over that hoop does suggest something.
But I would say you're arguing. I understand. Obviously, it's a completely plausible argument, but you're arguing with absolutely no evidence that it's just the way we do it. It's just it's like diltiazem drips. I mean, we just do it. I mean, it's crazy. So I don't know what you think about this, but let me just throw it out there. I mean, this is 2020. I mean, we had to memorize stuff back then because there was no really way to go to the library. You had to know the long QT syndromes. Now I've got this smartphone. I can just look it up. Pretty soon, ECGs maybe not a good example. I love ECGs. I think it's a great, I love, it's why I went into cardiology. But I make no mistake, there's going to be a computer that's going to be able to read EKGs better than us, for sure, pretty soon. And you know, why can't, I read a study that you can train yourself to do point of care ultrasound. We have all these tools that make the things that we spent so much time learning easier. And everything is easier now. So that argument, I understand the SEAL Team 6 thing, but I think that we have 2020 is different than it was in, say, the 1970s, 1980s.
I think it's so clear that I think it would be unethical to randomize a patient to a NP only ER.
Oh yeah, but I mean, we have colleagues who thinks it's unethical to randomize Impella versus no Impella. So that's not far-fetched.
Right. But I'm going to come to Anish's defense, to my co-host's defense, John, because I think so. I'm going to try to articulate what he's aiming for a little bit better, but I'm going to preface that by actually countering the philosophy of medical conservatism the way you've articulated it, because the way you've articulated it, it all centers about outcomes, and I don't see that the role of the doctor is to be an outcomes optimizer, right? And I don't think you do either, by the way. So I think you're a fake medical conservative, because I think you're a better doctor than you are, than you claim you be. So I don't think you are. I don't think it's impossible for you to go into a room and to tell to your patient to their face, I'm an outcomes optimizer, which means at the end of the day, it doesn't really matter what happens to you, so long as overall there's net benefit, and and net benefit outweighs net harm. This is not medicine. Medicine has nothing to do with outcomes. Outcomes is sort of a surrogate. Even hard outcomes are surrogates, right? So outcomes, so all this focus on outcomes, I think, is misplaced. So there's something to medicine.
Ivan Illich would agree.
Right. There's something to medicine that is beyond that, that has to do with what Anish was talking about, which I think is it's a certain commitment, not necessarily a touchy-feely commitment, to holding hands and whatnot, because there have been some, I think, very good doctors who, maybe are a little rough in their bedside manners, but nevertheless, there has to be a commitment to take into consideration the entire person, right? The entire patient, along their various dimensions, and to understand health, meaning to understand physical, bodily nature, human nature, understand these things, understand causes and effects, be rational, be scientific about that. All of this is sort of a body of knowledge and a commitment, right? So it's the combination of the body of knowledge and the commitment, which constitutes, the ideals of modern medicine. And the only reason right now going in medical school is better than not is because we still have a very faint trace of linkage to the old tradition from hundreds of years ago, except that it is completely being eroded. It's being eroded by the bureaucratization, by the mechanization, by all the disregard to what really the essence of medicine is, which is not outcomes, but it's really a focus on the patient and on what health is. And we've disregarded that for decades and even a couple hundred years, as far as I'm concerned, if you look at it philosophically. But nevertheless, there's still sort of a tradition that is still being passed on in a way that we can't really articulate, but it's there. It's sort of, implicit and whatnot. And it's enough that I, with Anish, would refuse to randomize my patients to an ER, that is manned by a nurse practitioner and not by a doctor. So that's what I would say.
Yeah, perhaps. I don't want to discount that. I mean, not every day, but many days, I look back on the people who mentored me through Indiana, and I have a couple colleagues from Indiana. We call it like the Indiana Mafia. But I mean, we go back to the old teachers that we had, and the care that they took to see us through, to see these things, and we have that. And so I think it's beautiful, it's true. But the question is whether it's necessary to change outcomes, not just outcomes like adherence to heart failure medications, but outcomes about living and dying, and also patient satisfaction. But I think we learn a lot of these things that are important in medicine, not in these classrooms and being a scut monkey for residency and internship. We learn it over time, and we learn it, and a lot of it is inherent. Don't you think that we're just caring people are caring people? And I'm just not sure that you need
John,
medical school for that.
Average, again, I think average outcomes, the outcomes of the average is a bad way to look at it, because if the issue with not having a ton of training in healthcare or being less experienced in healthcare is that the errors you make, the bad errors you make, you may not, on average, you may do just fine compared to somebody else, but the bad errors you make, the misses you make, the scale of them are no doubt going to be much, much, much larger. Just look at within medicine, right? The errors that interns make compared to the errors that senior attendings make. It's not that senior attendings don't make mistakes. It's that the type of errors the senior attending makes are much, much more, intelligent errors, if you will. Whereas the intern, again, and that's why interns have so much backup and so much fail-safe, right? Like the interns, you get upset if you don't, rise up the chain and don't let X, Y, know. But without that backup, I mean, can you imagine having interns be independent? So I think the scale of errors you make is very large. So, the types of things like the chances that, somebody coming in with a puncture wound a puncture wound to the foot, and the chances that a NP will suture it when they should be washing it out, versus the chances an ER physician, an ER attending does that, that's a very, very different scale. Now, on average, maybe it'll be okay, but that's a major issue in terms of why you don't want to randomize patients to folks that don't have the clinical training.
Let me tell you another story.
Experience,
So I think about this. So when Stacy and I, my wife Stacy's a palliative care physician, and she's a year or two, she's two years behind me. So we rotated together. We met in Indiana, and we did rotation at the VA, and I was a resident. She was I think I was an intern or second year, and she was a med student on the service. And we had an attending who came over. Back in those days, the attending would come once a day for about 20 minutes. We'd tell him what was going on, and he would never see. It was us. We were running internal medicine service. Okay, so it was me and medical students, and I really don't think those veterans had any worse outcomes or did any worse than if there were attendings running it. And I may be wrong about that, but I really think that, we probably made some errors, but when you talk about errors, there's backup. I mean, the human body doesn't just die from one error. There's people you can call. There's people for help. There's, radiology helps us. We have biomarkers. You can't miss a MI anymore because of high sensitivity troponins. So there's a lot of things that I think you overestimate
I trained in a very similar environment, and a very, and where there wasn't a lot of, and it was a fantastic training experience. But you can't there's a trade-off. You can't not believe that there are errors that are being made. And again, this always happens in an indigent or a VA population, which is kind of it's not. I mean, essentially, we're training with with patients like that because nobody else really cares about them, and we're it. And it's a fantastic training environment. But I can't believe you can't. Do you really believe that we're not making?
I'm not sure
sizable errors there?
because we cared a lot. We're thinking,
Oh yeah, we cared.
We cared.
We were there.
Holy shit, we're probably screwing up. So we were reading, we were studying. We didn't have smartphones then, but if we did, we'd be looking at it. We'd be talking to people. We'd be calling the the CV resident. We'd be calling the HEMONC fellow. We'd be calling all these people.
Lots of backup. That's lots of backup, though. Lots of backup. That's you have a cardiology fellow, etc. So yeah.
Well, but why wouldn't a nurse practitioner do that? If he or she cared, she'd be like, well, crap, I don't know what this is. I better call somebody. I mean, come on. Phone a friend is the most important thing, that is the most important tool that a clinician has. I'm on my phone or texting people all the time because, I mean, and I think a nurse practitioner or PA can do that.
Patients deserve to know that, and they're not going to know that in the system. Patients deserve to know that the folks that they're being taken care of, like, when they're going to be calling, they're going to be phoning a friend a lot. So when when somebody comes in with chest pain in the ER, and do you want an ER? Do you want a nurse practitioner looking at EKG to decide whether or not this person needs something, or do you want a cardiologist looking at it? And I think the problem I have is that it's fine if you want to let the market kind of decide. Then make sure that everyone knows that this is an NP run only ER, and you decide with your dollars whether you want to go there or you want to go to an ER that I run that has cardiologists looking at every EKG. Fine, but that's not how it's going to happen. What's going to happen is you have these massive systems, and they're going to show up. Patients are going to show up, and they're going to be seen by someone. It's a provider, and the provider moniker exists so that we're all flat and the same. And patients don't know. So that's my major issue. Not that I don't think, fine, take away license, let NPs do it, because obviously there's a different training program that they have lots of experience and good eyes, and okay, let's leave it up to folks to decide that. I don't think they would decide that. What's happening right now, I think, is it's a little bit of a con game, and the folks that are really going to benefit are the folks that are up top. No, it's not going to be patients. It's not going to be physicians. It's going to be the folks that are, and by the way, even though they're going to be paying NPs much less than doctors, that price differential is not going to be passed on to the system or to patients. So I just see a lot of potential for abuse of it, though I'm sympathetic to what you're saying.
Right. Well, I want to let John have the last word by quoting actually a sentence in your piece that I think is very true. Doctors have long, you say at the end, finally, doctors have long held a monopoly on medical practice. The medical guild protects us mostly through convincing the public and lawmakers that there's a need for certification and control of the supply of doctors, and you want that to change. And with that, I'm in complete agreement with you. And I think if we let that happen, I think we would have medical schools the way Anish wants them. We might have nursing schools and many different kinds of ways of providing medicine that people would choose at the end of the day. This is obviously a conversation for another time, but it's been great. I think it's I'm really I want to applaud you again, John, for putting yourself out there so courageously, knowing full well that you would be on the receiving end of a lot of ire from doctors who feel very entitled by the MD after the MD initials after their names. And you've given us a lot to think about. So I thank you very much. Hey, anything else
I really want to
before we leave?
Yeah, I want to say one thing. I want to first say thanks. And I want to say, when we talk about courage, when we talk about who's courageous online, I want to really give a shout out to you guys, because I listen to your podcast a lot. And I think to myself as I'm listening to it, my gosh, these guys are really courageous for even talking about this. So kudos to you all for doing that. You guys are far more courageous than me, for sure. So good on you.
Thank you, John. And thanks for taking the time.
Okay.
And we look forward to reading you again.
All right.
Take care.